Yeah, I will try to give you an overview of the viral and immune targets that are being addressed to cure HBV infection today. So just as an introduction, because you're mainly specialists of HIV, chronic HBV infections really remain a major public health problems. There are more than 250 million chronic carriers of HBV worldwide. So this is more than HIV, more than HCV, and clearly HBV is not at the top of the media interest. But still, it is also the main cause of liver cancer worldwide. So this indicates that it has a real public health impact. So as you know, there is a vaccine that is efficient, but it's not applied largely enough to prevent all the new infections. So we should work on that. And there are antiviral treatments that have been validated, which are nucleoside analogs and interferon, that we can prescribe to chronically infected patients. So the current situations in terms of antiviral therapy, and mainly with nucleoside analogs, is the following. So with nucleoside analog, we can induce viral suppression in the majority of patients, whatever the stage of liver disease. And this is accompanied by an improvement in liver disease, decreased inflammation, fibrosis, and so on, and with a decreased incidence of liver cancer, hepatocellular carcinoma. But the risk of HCC is not eliminated despite viral suppression. Another point is that the rate of HBs antigen loss, so the marker for chronic infection, is at maximum 10% after 5 years of viral suppression. So it means that in the majority of patients, therapy needs to be lifelong. So what are the barriers to eradicating HBV? So you see on the left panel the viral life cycle. So I don't have time to go in detail into this, but one of the major issue for viral persistence is the persistence of a viral form which is called covalently closed circular DNA, CCC DNA. This is an episomal form of viral DNA, so it's not integrated, but this is the template of all the viral transcript and thus a key player in viral replication and persistence. CCC DNA is like a viral mini chromosome. It's chromatinized in the nucleus, and it is not affected by nucleoside analogs or interferon. The other important point is that in chronically infected patients, we have defective adaptive responses. The CD8, the HBV-specific CD8 responses are defective, as well as the B-cell responses, and there are inefficient innate responses. So if we want to tackle HBV persistence, we need to work both on the viral life cycle and CCC DNA and on the defective immune responses. Currently, the goals of future therapy have been defined by the different liver societies, really it's the idea is that we would be able to achieve with a finite duration therapy a clearance of HBs antigen that would allow the treatment to be stopped. So there are several definitions of cure or treatment endpoint, and the consensus is now that we need to work to achieve a functional cure defined by HBs antigen clearance of treatment that would be accompanied by the persistence of low level of CCC DNA as well as integrated DNA. And there are more ambitious goals that we may see at some point, maybe in the future, which are complete cure and sterilizing cure. So the complete cure would be defined by the complete clearance of cccDNA, and the sterilizing cure by not only the clearance of cccDNA, but also integrated viral DNA sequences. So to achieve a cure, as you understood, we need to develop antivirals, but also immune-based therapies. So this, we need to rely on drug discovery efforts, also discovery of novel biomarkers to assist the clinical development of new drugs. And then in the end, if we get real assets to achieve functional cure in a high proportion of patients, we need also to solve the issue of access to care in patients who are living in endemic area with low incomes. So here you see the different treatment concepts that we have regarding chronic HBV infection. So there are direct antiviral approaches. Some may be curative if they are targeting the cccDNA, the viral mini chromosome. It could be strategies to cure hepatocytes, but these are still at the preclinical stage. So most advanced approaches in clinical development are approaches that target the pre and post cccDNA steps, and I will go into more detail in the different targets in a moment. There are immune modulatory approaches that may involve either the stimulation of innate immunity with the stimulation of antiviral cytokines in the liver that may control viral replication or even decrease the pool of cccDNA. And obviously, the stimulation of adaptive immune responses is very important, not only on the side of T cells with different approaches that I will come back to in a moment, but also by inducing B cell responses to neutralize the remaining variants. So here are the different targets that are being evaluated nowadays and are already in clinical development. So I will go just step by step. So viral entry. So there was a major discovery 6 or 7 years ago now by a group in Beijing by Wen Wili, who discovered the cellular receptor for HBV entry. Although the virus was known for 40 years, the receptor is NTCP, so that's sodium taurocholate co-transporting peptide, NTCP, so that's a bile acid transporter, which is really specific for the interaction with the HBV envelope and really provides a mechanism by which HBV can enter the hepatocyte. And there are several inhibitors that have been developed, and the most advanced is Myrcludex, so that's a peptide that mimics the domain of the viral envelope protein that interacts with NTCP. And this peptide, Myrcludex, has been mainly developed in patients who have not only HBV, but also a co-infection with a Delta hepatitis virus, which utilize the same envelope, HBV envelope protein to enter hepatocytes. So this drug works on both the HBV and the Delta virus to inhibit its entry. Here, just to show you very recent data from the latest EASL conference in April. So that was a phase 2 trial where they compared the standard of care interferon versus Myrcludex alone or in combination with interferon in HDV infected patients. Just to make a long story short, so I'm not sure we have a pointer here. The study showed that with the entry inhibitors, they could see on the upper panel a decline in the Delta virus load in the serum of patients. And interestingly, also on the lower panel, in the combination arms, they could see a decline of HBs antigen in the serum of patients. So this is really promising for Delta, because these patients are usually in a dead-end situation for treatment. And now there are phase 3 trials ongoing to treat Delta with Myrcludex, and early access program are starting in France and in Europe and probably elsewhere. But so these entry inhibitors, they are clearly interesting because they can inhibit new round of infection. The decrease of the pool of this viral mini-chromosome may require long-term administration. The real question is how we will be able to combine with other drugs to accelerate the decay of cccDNA in the liver so that treatment would be a finite duration. The very interesting class of molecules now in development is capsid assembly modulators. So there are different categories or families of drugs. The first class was discovered 15 years ago or so, the heteroaryl dipyrimidine derivatives, or HAP family, and there are many derivatives, lead to formation of capsid with aberrant morphology, and which lead to the inhibition of our replication. And there are another class, which is a class called class 2, phenylpropanamide derivatives, and there are also some other classes or subclasses of capsid assembly modulators that belong to the same family, which preserves the morphology of the capsid, but prevents the encapsidation of the pregenomic RNA, and this leads to inhibition of the viral DNA synthesis. Here you see a list of drugs that are in development, and at least 4 or 5 are now in clinical trials. I will show you just one example in a minute. So when you think of what could be the advantage of a capsid assembly modulator, you could say, well, nucleoside analogs, they inhibit the viral reverse transcriptase, so inhibiting viral DNA synthesis from pregenomic RNA within the nucleocapsid. The capsid inhibitors, they can act at the step prior to the nuke, so by preventing the correct nucleocapsid assembly, but also at a step further, which is the recycling of this nucleocapsid to the nucleus, which maintains the pool of the viral mini-chromosome. And this was shown very elegantly in cell culture experiment, where when the drug is administered prior to inoculation, then it prevents the formation of cccDNA. So this may have an additional effect on the long term to achieve a decay of the viral mini-chromosome. Here's just one example of clinical trials, because I cannot show you all of them. A recently disclosed trial from Janssen, but they are also from Roche, from Assembly, Arbutus, and others, where you see here in a phase 1b study a very nice decline of viral load in serum in treated patients after 4 weeks of therapy. So there was no side effect reported, and now phase 2 trials are ongoing with different drugs from different companies, with now 24 weeks of treatment that will be shown in a few months at different congresses. So we'll see how it goes with these drugs. Clearly, they have the potential to decrease the pool of cccDNA on the long term. There's opportunity to combine with nukes, to have a better viral suppression and also to combine with other immune interventions. So the long-term safety profile is obviously not known, but the first data on phase 1b are quite encouraging. We could be a little bit less enthusiastic and say, well, these drugs are just suppressive, so the real issue will be to see how we're going to combine with other drugs to make them curative. If we go next to the different stages of the life cycle, we can target the viral transcript, and there have been quite some excitement with siRNA. And you see here the different companies that have been involved in siRNA development. And I think the most where the most advanced work was done was with Arrowhead, which now has made a deal with Janssen. So they did extensive studies. So at the beginning, they were targeting the 3' end of the viral transcript because this is the 3' end is common to all viral transcripts. So that was kind of reasonable to assume that by targeting the 3' end, they would kill all viral transcript. But actually, what they had to encounter a problem is that these target on the 3' end may be affected by integration of HBV DNA in the host genome and leading to truncation of the 3' end of the transcript. So they had some kind of unexpected data in the first phase 1 clinical trials where they didn't show the expected decline in HBs antigen, which was their surrogate marker of activity. So what they did is that they went back to their strategy and they redesigned their siRNA a little bit upstream of the truncation of the integration site so that they would really target all transcripts independently of integration. And they went back to clinical trials with new formulation. Now it's formulation with GalNAc so that they can have a sub-Q administration. And here are the results that were just shown a few weeks ago at EASL. And they showed that with their new siRNA formulation, they can have a decline of HBs antigen by more than 2 log after just a few months, 3 months, which has never been shown with any other drugs that are available now. And they did also some interesting pharmacologic studies for you is that they studied either a monthly administration or a shorter dosing interval, a weekly administration, and actually, which is shown on the lower panel, and they didn't see differences in HBs antigen decline with a shorter dosing interval. So now they are going with a monthly dosing interval, and they achieve quite an impressive results on the decline of HBs antigen, which is really our endpoint for therapy currently. Clearly now the question is, will this be enough? Because if the pool of cccDNA is still maintained, having a decline of HBs antigen may not be sufficient. If we have to stop the siRNA at some point, there will be a relapse if the cccDNA is not eliminated. So now, clearly, the questions in the community is whether this will be sufficient to restore antiviral immunity so that it will eliminate the residual infected cell, or will we need to have combination with other strategies. And there are other technologies that are under investigation, antisense oligonucleotides, locked nucleic acid, and also RNA destabilizers. I don't have time to go into detail. There are some other interesting drugs, which are nucleic acid polymers developed by Replicor, which are supposed to have entry and post-entry antiviral effects. So they seem to prevent the release of HBV particle in the circulation. And what they showed in the latest clinical trials in combination with TDF, so tenofovir that you all know, and interferon, is that they had quite a, if you look at the upper panel, a very nice decline of HBs antigen in these patients, and even anti-S antibody seroconversion. So they achieve approximately 50% functional cure in the patients. What is remaining a matter of discussion in the field is that this decline of HBs antigen is associated with ALT elevation, so ALT flare, as you can see on the lower panel, for which the mechanism is not known, whether it's restoration of antiviral immunity, killing infected cells, or whether it's some toxicity effect by different mechanisms remains to be determined. And there are now a phase 2 ACTG trial that is planned with NIH. Now, besides these direct antiviral targets, there are obviously immune-based therapies that are being evaluated. And there are two ways to restore antiviral immunity. One is to boost innate immunity. And this has been mainly done with TLR agonist, and I will show you some example. But we can also think of boosting adaptive immunity by different strategies, either by blocking inhibitory signals because the HBV-specific T cells are exhausted in patients, or by stimulating the few cells that are still around in these patients by vaccine therapy. And there are also some very clever ways that are being evaluated, which are to engineer HBV-specific T cells to redirect these HBV T cells to the infected hepatocytes. Here, I will show you an example of a TLR7 agonist that was developed by Gilead. It gave very impressive results in preclinical models, in the woodchuck model of HBV infection, in the chimpanzee model, they had very nice results, decline in viral load that was sustained. And then they went to clinical trials, so they showed a nice dose-dependent induction of ISG15. So there was indeed target engagement with their TLR7 agonist. But when you look at the HBs antigen decline on the upper right panel, you see that there was no significant HBs decline in the patient. So this trial failed to show a benefit in this patient, despite very good and promising preclinical data. So there are also TLR8 agonists that are being developed, and I'm sure you have them for HIV as well. And there's another one, another innate immunity booster, which is Inarigivir. This is a RIG-I agonist developed by Springbank, which has two modes of action. One is to interfere with the viral polymerase mechanism, so a direct antiviral effect, but also a RIG-I activation, so that there is a type 3 interferon stimulation. And they presented again 2 or 3 weeks ago at the EASL meeting their first result of a phase 2 trial where patients received Inarigivir at different dose, and then it was followed by tenofovir administration. And you see here the results where it was interesting because it was the first time we could see with a single agent a decline not only in HBV DNA in serum on the upper panel, but also of HBV RNA, which is another marker for target engagement, and HBs antigen decline as well. So it's modest, but it has all three components. So now we will see how we can combine with other approaches. Now, regarding adaptive immunity, there are ways to stimulate or try to combat the exhaustion of T cells with PD-1 blockade. Well known in the cancer field, HIV as well. So it was shown like almost 10 years ago by ex vivo studies looking at exhausted T cells from the liver of infected patients that if you block the PD-1, you can restore the activity of the T cells. Now there were also other trials that look at therapeutic vaccine, but again, they didn't show a benefit in the clearance or decay of HBs antigen, despite some stimulation of adaptive immunity. So then the question was whether we can combine a checkpoint inhibitor to restore the activity of exhausted T cells plus a therapeutic vaccine. So this was done in a very carefully performed trial where in this trial patients were already suppressed with tenofovir and they received a single dose of nivolumab, very low dose, either alone or in combination with the therapeutic vaccines that failed in the past. And what they showed is that in the combination arm, there were, if you look at week 24, you seem to have a better, a little bit more HBs antigen decline in serum in the combination arm versus the monotherapy arm, although there was one single patient who cleared HBs in the monotherapy arm, but this could be due to maybe to a very small size clinical trial. So this is still going on, and we will learn more in the future. Here, just to show you again all the different targets that are being evaluated and are in clinical development. And now, obviously, people are trying to combine these different strategies. So we'll not go through this. They are all in preclinical models, so before going to clinical trials. So the idea will be to see how we will combine direct antiviral approach with immune-based therapies in the future. And for this, we will need also novel biomarkers to assess target engagement and predict very early on the efficacy of therapies. And I don't have time to go through this in detail. And there are innovations, just the last slide, that just came out in the latest few months. One is a drug that has been shown to target cccDNA in preclinical model, in cell culture experiment, and in mouse experiment developed by Roche, where they showed an effect on cccDNA. So this is really promising. And there are approaches for immune-based therapy where we can redirect T cells by engineering the T-cell receptor for HBV and try to target HBV-infected cells. So this is really where the field stands. So there are a lot of excitement, and we hope that there will be some new avenues in the next few years to treat HBV. And I would like to thank my collaborators in Lyon and collaborators worldwide. Thank you.